Welcome to the Let's Talk Health Forum. I'm Dr. Dan Pavlik Jr., where we're always trying to bring the alternative world of healthcare and the traditional world of healthcare together. Today on the show, I've got a doctor, Dr. Joseph Ibrahim from the Orlando Health Surgical Group. He's the director of the Orlando Health Surgical Group, and he works in critical care surgery as well as general surgery. Very, very interesting show today. So I welcome him. Appreciate it. He was in surgery earlier today. He made it in for the show, and thanks for coming on. I really appreciate it.
Yeah, my pleasure. Thanks for having me.
So you go by Dr. Ibrahim. Do you go what do your colleagues typically call you?
Joey.
Joey. All right.
Yeah, Joey's fine.
Typical, guy just like anybody else,
Just
right?
want to hang out. Yeah.
So,
exactly.
Seems to be very down to earth and laid back, which is what we all appreciate. So, tell us a little bit about what got you into healthcare. I mean, what got you into wanting to become a surgeon? Of course, a critical care surgeon. What got you to get into all this?
I did know pretty early, earlier than most of my friends, but not something I planned on. As a kid, I had family that were in healthcare, so I actually had always said, I don't think I want to do healthcare. You have to work hard. It's long hours. It's hard on the family. Maybe I'll do something else. And growing up in a small town, I played every sport possible and really loved coaching, really loved the team concept. So, I'm going to teach and coach. And as I got further along into that, I had some really great mentors who said, look, you can coach and do something else. You've got a lot of other opportunities. Why don't you take advantage of some of those? So I migrated from that to physical therapy. And I was fortunate enough, even at my small public high school, they offered physical therapy rotation where we got to some exposure. And I remember doing the physical therapy, following them, and I was just like, I want to be more involved. I want to be more involved with the actual hands-on initial treatment. Mm-hmm. And was then fortunate enough as a junior, senior in high school to observe surgery where they actually clean out the carotid artery. My mom was a nurse at the VA, so I got to observe that, and I was hooked at that point.
Right.
So the carotid endarterectomy was the surgery that got me. I was like, I want to be a surgeon at this point. And was just really blessed enough to have the opportunities. Got into an early entrance program at East Tennessee State University that accepts you after your freshman year. And as long as you maintain your GPA and score the score you need on the entrance exam. And it all just kind of fell into place. So that's how I ended up in medicine in general. As far as surgery goes, it's a whole another ball game. As a medical student, you rotate through everything, and I was one of those. I'm much better person to person. Like I love working with people, getting to know people, getting their stories. And my first rotation was psychiatry. I remember coming home and saying, I'm gonna be a psychiatrist, and I just really loved every rotation. So I was really torn between, when it came down at the end, I was torn between me doing family medicine and general surgery, which a lot of people say that sounds crazy.
Mm-hmm.
But I was fortunate to do some rural rotations with family practice doctors that did some training at locations where they're training missionaries. And so it was a family practice doc in rural Kentucky, but he would do an appendectomy. He dealt with ectopic pregnancies, but then he'd be treating hypertension and different things. And I was just like, wow, this guy does everything. And this may be what I want to do. But then as I looked into that further, I found that really isolated where you could live in the country. And I wanted to be able to go anywhere. And one of the things that, as I got more and more into surgery, that I told myself is I want to be able to take care of whatever comes through the door. I may not be able to do the definitive surgery, but I want to be able to at least get them fixed, get them stabilized, and then get them to the right person. And that kind of parlays into how I ended up where I am today.
So, when we talk about general surgery, and then we talk about critical care surgery, the trauma aspect of it. Obviously, you came to Orlando, the level 1 trauma center at
Right.
Orlando Health or ORMC. The mindset, is it the same or is it different aspects? I mean, how do they blend together? How do they flow together?
Yeah, I mean, it is different in ways, different in some ways, similar in others. So with regards to how you set up your days, right? I think critical care versus general surgery, very different. General surgery, for the most part, very planned out, very scheduled. You get your imaging, you see the patient, you go over everything with them, and you kind of have a plan. When it comes to your critical care days, you don't know what's going to come through the door.
Yeah.
You know, you can have somebody run over by a car, or fall from a ladder. Those are common things, the most common things that we see here in Central Florida. Or you can have somebody with an abdominal disaster of a perforated colon or something like that. So all of those, though, lean themselves more towards the critical care mindset, where I've got to be able to take care of whatever comes through the door. And you really develop during your training a very systematic way of thinking, like almost like check boxes. I often equate it to a pilot, right? Because you have your checklist. We have lots of checklists in critical care, from when we're rounding to when we're starting an operative case, to even at the end of the case. They kind of have a checklist they do at the end, make sure everything's accounted for. And so, I think when you talk about the comparison of general surgery versus critical care, they're both have to be able to do the same thing. Both have the same when it comes to think about the physiology and the surgical technique. But when it comes to the planning parts, a lot of my general surgery colleagues, they say, I don't know how you deal with that. I couldn't handle not knowing what's going to come in.
Yeah, you got to be able to think under stress. And say, yeah, hey, I got to do this or I got to do that. Right. I can understand how not everybody is designed that way.
Right. We're fortunate enough, most critical care and trauma systems, they work as a team. I mean, I can't emphasize that enough. And I think that's one of the things that drew me to it, playing sports and dealing with things like that as a kid. It's very much a team concept. And I saw that here when I first came as a fellow, from the ICU nurses, from EMS. I mean, really everybody. It really works as a team. Heck, a busy night, I mean, you're really working closely with environmental services because they're having to get the trauma room ready for the next case. So you get to know them well and appreciate them and thank them. So trauma and critical care is so much more of a team aspect, I think. General surgery is too, but not to the same level.
No, yeah, I can understand that. So what days do you do your general surgery clinic, and what days do you do the critical care?
So we generally do a week at a time of those. So with our group in particular, 11 of us. So 1 in 11 weeks, I'll do the critical care week. And during that week, to your point, I'm just critical care. And in fact, as we've gotten busier, there was a time there where we would say, okay, you can schedule some general surgery cases in the afternoon. But we've gotten so busy and grown so much now.
What does your day look like as in a week of a critical care doctor?
So you come in around 7 or 8 o'clock in the morning. Usually get some sort of checkout from the person the night before of anybody that they're worried about. You then start rounds, meaning seeing all the patients. And it's typically, in our busier ICU, it's around 16 patients. And you have a team of, fellows and residents, but also nurses, registered dietitians, respiratory therapists. They are all, like I said, very critical parts of the team. And again, you'll go through each patient, and it's very much a systematic way going through each organ system from, starting at the neuro and then pulmonary, cardiac, and so on and so forth, till you hit every system. And again, the thing I like best about it is everybody has the ability to speak up. Pharmacists, I forgot to add them. They're obviously very crucial to that team. But you go through each of those aspects, and each team member has the opportunity to speak. And then we also have a checklist at the end of that, just of the day-to-day things that can easily be forgotten but are so crucial, like prevention of blood clots, like you and I were talking about earlier, prevention of ulcers in the patient that's severely stressed, right? They're on multiple blood pressure meds, they're on a ventilator, their body is at the most stress level it can be, and when that happens, you're at increased risk to develop ulcers. So are they on medicine to help prevent that? Just little things like that if it slips under the rug, that can be life or death.
Yeah, and we'll get back to the prevention aspect here in a little bit, but moving on, you're the director of these 11 physicians. What does that entail? I mean, do you guys have to meet daily? Do you have to meet every other day, once a week?
We meet weekly, and that was set up way before I took on this role. Fortunately, like I said, a lot of good mentors along the way. So we meet every week, every Monday. And it's good practice to just, again, say, hey, are we getting too busy? Do we need to change the way we practice this? Do we need to make some adjustments? Do we need to hire more?
Everybody's got an opinion, too. 11 opinions.
That's right. The more people, the more opinions. And sometimes it's interesting, especially strong-minded surgeons, as you would imagine. to get everybody to mesh, but we're very blessed here. We've had a great group that's been here a long time. Most of us have been here at least 10 years and have got along very well. So I have no complaints when it comes to that. But that is an interesting part of the job, not just here. I did some of that as trauma director before, working with the different disciplines, neurosurgery, facial surgery, orthopedic surgery, and we do that on a day to day. But when you're a trauma director, you have to make sure everybody's playing nicely in the sandbox. And
Yeah.
I think, that's one of the reasons that I got in these roles is I've just been blessed with the ability to
Communicate
talk to people,
well.
communicate.
You're a likable
Yeah.
guy.
How do we make sure? How do we come halfway for both
you don't
sides?
you don't seem to have an ego, which some doctors can. So
Dude.
I mean, it's
Yeah,
but that's got no role really in healthcare. It's just unfortunately it happens, and you see it.
absolutely. Well, my mom was a nurse, so I think she really emphasized, hey, nobody, you're better than nobody, right? The lowest person on the totem pole is the same as the highest. You guys are all trying to get the same job done. Like we were talking about, the focus is the patient.
Mm-hmm. Absolutely, the patient-centered healthcare model. I mean, that's what we're trying to teach, and we're trying to get anybody that watches this to make them understand that that's what's important. So I want to go through quickly. I read through your bio, and it says your specialties. Obviously, we talked about the general surgery and the trauma, but hernia repairs, thyroid surgery, appendectomy, gallbladder removal, burn surgery, catheter placement, splenectomy, and of course the critical care aspects. What would you say of those surgeries that you see all the time, like consistently, weekly, daily, whatever?
Definitely hernias. That's been a focus for me, and it's changed over the years, right? When I was in training, everything we did was open surgery, meaning you make a big incision, you go in, you repair the muscle, you put mesh in, maybe not. To now where that's what the last case I did before I came here was an inguinal hernia that we fixed robotically that has 3 8-millimeter incisions, and it's so much less painful. Like I remember doing them, in training and watching the poor person walk into their post-op clinic visit, and they're leaning over, hunched over. Now they'll walk in, they're like, "Doc, I had to remind myself I had surgery. Like this was really almost painless."
Mm-hmm.
And that's what we want, right? We want to have, equal results. Obviously, that's the first thing. We want it to be fixed. But if we can do it with less pain and get them back to their work, their family, the life that they love quicker, then that's gravy. That's a bonus.
So, how many years ago were they doing it to where you guys were cutting people open to fix the hernia as compared to now laparoscopically, robotically?
Right. I mean, if you go back even about, I finished, in 2009. So if you go back then, they were just starting to see some laparoscopic more and more, but the quality of it wasn't great. About, I want to say 6 years ago, we started doing, 5 or 6 years ago, seeing robotic repairs. And I'll admit, I was one of the naysayers at first. I'm like, oh, we've got hernias down. They've been around a long time. And then I said, well, let's go see what this is about. And, got into the training, looked at the literature, which there wasn't a lot at the time, but there's obviously been a lot more since then. And it's just been mind-boggling. You see less wound infections because you're having smaller incisions. It's kind of makes sense. There's no question about it. Less mesh infections by doing it laparoscopically, and again, less pain and quicker recoveries. So, but the robotic's been the last 5 or 6 years, and there's some other things that the robotic method gives us. The magnification from the camera is unbelievable. Like you can see things that you couldn't see before, even with the naked eye or even laparoscopically. There's some things that the robot allows us to do that are just easier. It has a certain camera lens that you can actually give the patient some medication and look at the blood flow to certain areas. You can look at the bile flow if you're doing a gallbladder surgery. It's just really amazing how that has changed, and again, just since 2009.
And I would imagine there's more stuff. I mean, it's ever changing, right?
Absolutely.
There's more stuff on the horizon. I mean, have you heard of anything else interesting that's out there that you just haven't used yet?
Yeah, I was just talking with one of my colleagues yesterday. Like I mentioned, my camera is about 8 millimeters. There's another camera that just came out that they're using that's 3 millimeters, literally like a needle that they can put into the abdomen and use that to place some of the other things they need. So again, less incision, less pain, quicker recoveries.
Talking real quickly about hernias, as a chiropractor, obviously we see a lot of low back pain, probably one of the number one complaints. So as muscle hip flexor injuries,
Mm-hmm.
groin injuries. How often do you see that instead of the person thinking they had a hernia,
Right.
and it comes down to, oh no, you strained your hip flexor, you strained your groin, you hurt your back? How often do you see that?
Yeah, I mean, you see a fair amount, especially in younger folks. I don't see as much in older. Usually, when the older ones coming in, it's really a hernia. But younger folks definitely the more active.
Mhm.
Definitely see that. And honestly, the other thing I see though is if they have, especially if they have an abdominal hernia, not necessarily an inguinal, but abdominal wall that's significant, meaning large, I think they have impact on their back.
Yeah,
I
big
have a
time.
lot of people, or the other ones I see is in the postpartum patients that have maybe a large, what we call diastasis, just a very thinned out muscle from where the uterus kind of pushed all the
Mhm.
muscles out to the side. They're coming in and they have no functional abdominal wall, and all the strain is on their back.
Yeah, and there's specific physical therapists that work on that problem,
Absolutely.
and I've had those patients before. So,
Yeah.
are there any hernias that are you look at that you're like, we can't repair this? Like, is there ever cases like that where people are just, too big, or or is there always a fix?
I guess it just depends if they've had multiple repairs already, right? There's certain at a certain point you've burned all the bridges, so to speak. But the bigger thing is really their other medical problems. Those are usually the prohibitive things, like smoking. That has actually come out. American College of Surgeons strongly recommends, in our hernia center, which is we've developed throughout the system, that we won't operate on anybody that's actively smoking. It's just the risk is too high. Patients do poorly. It's a disservice to them, honestly, to let them go through all that it takes to go through a surgery, get to the recovery, and then have a bad outcome when we know it's going to give you a bad outcome. So that's one of the biggest things. Other things like obesity has a higher recurrence rate of hernias. But then the other thing that we see that we can't fix them is if their cardiac condition is too poor or their pulmonary condition is just too poor. Then those come occasionally. We're just like, sorry, this is just going to have to be watchful waiting. As we tell them, we warn them of the warning signs of, hey, you need to get to us if if you're having nausea, vomiting, if the skin's changing over top of it, because that's telling us the bowel's incarcerated, and then we're getting close to an emergent situation. And then we have to have that discussion of, we didn't want to operate, but now we kind of have to. It's risky either way. It's risky to operate, risky not to operate.
And then, I'm sure you have cases where you fix problems in these challenging patients, and a week, 2 weeks later, they don't make it because something happens because of the health condition was too bad. I mean, and that's got to be draining for you mentally. I mean, that's got to be really frustrating because, you did everything you could, fixed them, but the body just wasn't able to help itself. Right.
And you have those discussions, with them, and you get to, in having those discussions, you, like you're pointing out, you actually get very close to those people, and you get to know them on a very personal level, and those are difficult. Yeah.
Yeah, I mean, any of us in healthcare, we've dealt with that, where you do everything you possibly can, but they're 100 pounds overweight, or they won't quit some of their vices like smoking or drinking heavily or whatever else that they're taking. And that's the key as a physician that people have to understand is we want to help, but they also have to play their role as far as helping themselves, where that's where the prevention aspect comes into play, and eating properly and all the basic stuff that we've always talked about. But I mean, are there any other prevention aspects from your world that you would tell a patient outside of the smoking and the drinking? Are there any in the obesity, being overweight? But hopefully anybody that's listening, they understand that this is why doctors want you to be healthier because of the fact if something does happen that we can help, we can play a role. But is there anything else that we're missing that you see that you're like, oh, make sure you do this or that, or is it pretty much the obvious?
No, I mean, there's some little things especially more from a trauma standpoint that people, I was always taught trauma is not an accidental disease. I mean, we all know there are some accidents, but when I was taught that, what they meant was there was something that you possibly could have done to prevent. Whether it's climbing, we see a lot of people on ladders doing do-it-yourself projects. Get somebody to help hold the ladder.
Mm-hmm.
You really underestimate, even, you and I are pretty healthy guys. We fall from a ladder, break some ribs, that can really impact our lives and even potentially be life-threatening
Mm-hmm.
for some individuals. You can break hips, you can break legs, and it's devastating. So little things like that. The number one thing we see in the trauma center, everybody thinks it's car crashes or gunshots or this, it's falls. So that's, and it's making sure if it's an older individual, a parent that's getting old or whatever, do they have a shuffling gait or walk? If they do, are they wearing the right shoes?
Mm-hmm. Do they have rugs in their house? Do they have, things to hold on to?
Yes.
Yeah, all those different aspects play a role.
Or they have transitions between rooms. That's another huge cause for falls. So little things like that, texting and driving, I mean, that sounds like a no-brainer. Even running, I've gotten to where if I run, downtown here, I'll only have one AirPod in because, I want to listen for the cars and different things happening. So just being aware, being aware of your surroundings. Which, again, sounds like common sense, but
I mean, common sense is the best, though. Like, and we talk about it all the time, and people are like, "Oh, I could have thought of that, right?"
Right.
But you didn't. You know, it's like, but you have to be. If you don't, people don't know what they don't know, and they don't know your world. And once again, that's why this stuff helps. And just listening to these general snippets of information from a surgeon that sees it all the time, or getting information from a chiropractor that sees all these things all the time, and so hopefully people, get what they need out of a show like this. I actually, one of the things I also want to talk about too is outside of all the stuff we just talked about, you do some publications.
Mm-hmm.
I found it interesting that I wrote it down over here on the board that you do some vitamin D work with some critically ill patients. Tell me a little bit about how that works.
So we did that. Gosh, that's probably been around 2013 or 14. But we just more and more data was coming out in the critical care world about, hey, what role does vitamin D have? Everybody's getting diagnosed with maybe low and
Deficiency.
Yeah, deficiency. So I was like, well, we're in Florida, so arguably you should get more sunlight and more more ability to have access to vitamin D than anywhere else. And then our trauma population, especially in ICU, is typically a younger population. So we're like, these should be very healthy folks. Let's see if there's any kind of impact that first we just started with just measuring their levels, and then we found out, wow, overwhelmingly almost everybody was deficient. And more and more we look into it, there was some impact that it would have. Those that were deficient had longer ventilator days, longer ICU days. Maybe we're on blood pressure medicines, meaning pressors or meds to keep their pressure up for a longer period of time. So, with that, we said, gosh, should we, how do we, make an impact with this? Unfortunately, it's one of those things to do randomized control trial. It's really difficult to get IRB approval and all those things. So we never made that next step of, hey, maybe we should just give everybody vitamin D and see how it works. But that's where we got to with it. But definitely found an impact that these other things, whether it's multivitamins, whether it's vitamin D, having them at the appropriate level could significantly impact your outcome, whether it's a traumatic situation or a general surgery issue that you had, some unfortunate outcome and you're critically ill. You might do better with these things.
I mean, once again, when we do this show and we have all these different walks of life from the healthcare profession, it's just great to learn things like this and how people can stay healthy, right? And you're great at what you do, but if we do a better job, right, we may not have to see you. You know what I mean? But Dr. Joey Ibrahim from Orlando Health, general surgeon, critical care surgeon, I greatly appreciate you being on the show. It was very informational. I hope everybody got something out of this show today. And, I hope you tune in. And if there's no other comments or questions, we'll go ahead and be on our way. I know you're a busy man, and I got to let you get back to what you do.
Thanks so much for the opportunity.
Or have a good weekend.
Yeah, there you go. I'll take that too.
Appreciate you, my
Thank you.
friend. And we here on the Let's Talk Health forum, as we continue to spread the knowledge and information on healthcare and how to live a healthier lifestyle, bringing the world of alternative care and traditional medicine, together. So I'm Dr. Dan Pavlik Jr., and we will see you next time.